Okay, I think we'll get started. Hi, I'm Mike Saag from the University of Alabama at Birmingham, and welcome to this HIV 101 initial assessment, initiation of antiretroviral therapy, and monitoring of people with newly diagnosed HIV webinar. This is a webinar designed for folks who are relatively new to the field and kind of giving a lot of the background information that supports a lot of what you've probably already been doing, but maybe haven't seen the rationale for what you're doing before, or you may just kind of be getting a view of the landscape. And the purpose of this is to kind of bring it all into focus. Along with me today, we have two experts in the field, Dr. Roger Bedimo from the University of Texas Southwestern in Dallas, and Dr. Melanie Thompson from Thacker and Thompson in Atlanta, Georgia, in a private practice setting. But Melanie has been involved in HIV research for over 35 years. Next slide. These are the financial relationships. I'll let you look through those. And then just to kind of be complete, we have had at least one and often two unconflicted reviewers to look at all of our slides and to assure balance. Now, this webinar is supported as part of the Ryan White grant project through the Health Resource Services Administration of HHS. The grant number you can see here is through the AETC and coming out of Rutgers University in New Jersey. And the IAS-USA is the sponsor of the event in terms of CME information. IAS-USA is accredited by the Council for Continuing Medical Education for physician education, but we also have the opportunity to provide credits not only for physicians, including ABIM, MOC, or maintenance of certification points, but nursing contact hours, pharmacy credits, and pharmacy contact hours, or 0.15 FTEs, a CME, sorry. While you are having the experience of getting the data presented to you, every now and then there's going to be questions that pop up. You've already seen that in the demographic poll. You just choose your response, and the responses will be displayed after the poll closes. If you have questions, please use the Q&A button, not the chat button, but the Q&A button on the bottom of your Zoom menu, and that will get the Q&A, the questions to us, and we will get to as many of those as we can. We have the opportunity that even if we don't get the chance to present the answers online as part of the webinar, we can be answering them offline. This is the result of the poll that we have. You can see we have 143 people who responded. 30% are physicians, 3%, or actually 25% are either PAs or nurse practitioners, 5% nurses, and the remainder are pharmacists and health educators and counselors for the most part. So welcome, everybody. It's a great balanced mix of individuals. So I'm going to kick it off and give the initial overview. Dr. Bedimo is going to speak about complications of therapy, and Dr. Thompson is going to talk about primary care, but with a special emphasis on vaccines and that type of thing. So let me get this fixed. Are you seeing the full screen or the double screen? Full? Okay, so we're ready to go. All right, so I'm going to talk about the fundamentals of antiretroviral therapy, and we're going to talk about pathogenesis of HIV disease. We're going to talk about the initial assessment and initiation of antiretroviral therapy according to their clinical presentations. But let's start by going back to basics. So these cells represent in a person with HIV who has established infection. These cells are the infected cells within the body, and there can be millions of these cells at any moment in time. Now, there's billions of these types of cells, which are the uninfected and mostly resting CD4 lymphocytes, and they become activated about 1% of them of the body become activated. And the way the biology of HIV works is that these activated CD4 lymphocytes are the ones that are the cannon fodder for the virus. So the HIV really cannot infect resting CD4 lymphocytes. It's only the activated ones. So during the lifespan of the HIV-infected cells, they produce a given amount of virus. Those virions go down and infect the susceptible activated CD4 lymphocytes, and you get this kind of vicious cycle. What's fascinating is that these cells at the top, the HIV-infected cells, live on order of about a day. That's it. And they infect these cells that replace them in that 24-hour period. So there's incredible turnover to the point where there's about 1 to 10 billion, with a B, billion virions produced today by these cells, and they are in fact replaced. Those cells are replaced in a 24-hour period on average by newly infected cells. So this is a very dynamic event. We know that viral load, the amount of virus that you detect on an HIV RNA assay, is directly proportional to the number of cells in the body producing virus. So if the viral load, say, is 30,000, that corresponds to a certain number of cells in the body producing virus. If the viral load is 500,000, that also corresponds to the number of cells, but there are a lot more cells in that individual. And that's just the nature of the biology. When we give antiretroviral therapy, all we are doing is protecting the activated CD4 cells from becoming infected during that 1 or 5 day lifespan. And as these cells die off at the top, they are not replaced by newly infected activated CD4 cells. And as these cells decay in number, the viral load proportionately decays right along with it. So when you see a drop in HIV RNA following initiation of antiretroviral therapy, that drop is basically the decay and elimination of the previous infected CD4 lymphocytes dying off and not being replaced. And as long as somebody stays on antiretroviral therapy for a long period of time, that viral load will drop to undetectable levels and will remain there. And what we've learned over the years is that these viruses, these HIV virions, they're the culprits that are causing immune suppression. We always focus on CD4 lymphocyte counts. That's just an epimarker. That's not the pathogenesis. The pathogenesis is really from these HIV virions binding up, mucking up the works and the function of CD4 cells. And that's what causes the immune deficiency. How do you know that? Well, you know it because when you give antiretroviral therapy to somebody who has advanced infection with low CD4 counts, after about 4 to 6 weeks, what do you see? You see an immune reconstitution inflammatory syndrome, or IRIS, right? That's because the virus has dropped. The immune system's, in essence, wakes up and it becomes active again and so looks around and says, whoa, where did that pathogen come from? And it starts attacking. So that's how we know, among other things. For example, the other thing I'll just say briefly is that when somebody's on successful antiretroviral therapy, after about 4 months, 6 months, even if the CD4 count isn't rising the way we'd like it to, you don't see CMV anymore. You don't see Mycobacterium avium infections. Why? Because the virus, the culprit, the cause of the immune deficiency, is suppressed. Now, back when we discovered all this in the mid-90s, we thought, okay, great, we'll just treat with antiviral therapy. These cells at the top will die off. We can wait about a year, stop the therapy, and they'll be cured. Well, there's a complication, and that's these cells. Less than 1% of the total body infected cells don't die on the order of a day or 2 or 3. They actually can live for months, years. And it's this group of cells here that are really the ones that are the embers of a fire, that if you stop the antiretroviral therapy over a period of a couple of weeks, these guys will spit out some virus that will then come down here and initiate a fire, if you will, and start this cycle all over again. and the viral load will rise back up as the number of cells in the body become infected, and boom, you're right back at the same viral load you were before. So this is the barrier to cure, these latently infected cells, and we'll hear more about cure at the Ryan White conference, but the targets have to be these cells and eliminating them, much like you'd want to eliminate all cancer cells from the body. You can do that. So that's the basic biology in just a few minutes. And we know that it's best to use multiple drugs as antiretroviral therapy that target a couple of different areas of the life cycle. And why adherence to therapy, as you could see, is critical to maintain the success by blocking. Now, when I say different sets of the lifestyle, this is a CD4 cell. Here's the life cycle. The virus binds and enters the cell as single-stranded RNA. It then goes through reverse transcription to double-stranded DNA, integrates into the host nucleus, and then comes out here as an immature virion that matures and now is infectious for others. So the steps of binding and entry can be a target, reverse transcription, and inhibiting that enzyme either directly with non-nucleoside agents or indirectly with nucleoside agents, interfering with integration with the integrase inhibitors, and interfering with this maturation process out on the right-hand side that prevents this virus from becoming infectious, because the polypeptides that are initially produced as the virus starts to bud from the cell here, as we see this thing coming out, if you inhibit that protease that cuts those polypeptides into active peptides, without that cut, this virus is no longer infectious. The take-home point is that no matter what we do, this entry, reverse transcription, integrase, or even maturation, all we can do is protect an uninfected cell from becoming infected. We can do absolutely nothing so far to a cell that's already infected that lives for about a day or two. And certainly we don't have anything yet that can knock down those latently infected cells. If we could do that, we'd have a cure. We've learned over the years that starting therapy as early as possible makes the most sense. For those of us who were involved in developing that story that I started with about the 1 to 10 billion viruses a day, this is around 93, we did those studies, we were screaming, why do you want to wait? Why do you want all this churning to go on? We didn't quite fully understand that the virus was the cause of immune deficiency. That came a little later, but just the biology was screaming at us. But yet a lot of folks said, well, these drugs are toxic, etc. And ultimately, there was a randomized clinical trial called START that deferred therapy to 350 or started immediately, kind of regardless of CD4 or above 500. And there was a 57% reduction in mortality when you started with higher CD4 counts. Biology sort of made sense all along. I personally didn't see a reason for this study because it made so much sense to me, but a lot of other folks didn't buy in, and so now they bought in because the study showed this. The other thing that we know biologically is that the virus is inflammogenic. It stimulates the immune system because it's trying to fight this thing every day. These 1 to 10 billion viruses produced today, and it flails at it. And this is the evidence of activated T cells or CD8 cells in this case that are strongly activated. When you give antiretroviral therapy, that drops substantially. But notice that it doesn't quite make it. To someone who doesn't have HIV. And Dr. Bedimo is going to talk to us about the consequences of that smoldering inflammation that seems to put people with HIV on a path to having earlier morbidity from cardiovascular events, among other things that we know are related to inflammation. Well, now what do? We know this biology, we've got this down. What are the things? First off, obviously, somebody newly diagnosed, a history of physical and basic lab tests, starting prophylaxis if indicated, and all these data are available in a number of reports. The IAS-USA has the antiretroviral therapy treatment guidelines. There's the HHS treatment guidelines as well as the HHS-OI guidelines. All this is available to you. And then you want to start antiretroviral therapy. Again, I'd start it on pretty much everyone as soon as they're willing to go, but most are willing to start right away. And then what to start, I'll go into some detail with that right now. We know that the CD4 count, as a rule, is a great predictor of risk of opportunistic cancer, but it's not the cause of an opportunistic. In other words, biologically, as I've talked to you, I think the main cause of immune deficiency is the virus, but the CD4 count is a metric that says this is how badly damaged the immune system has been and sets people up for different OIs, and you can see them listed here. PJP at about 200 cells or so on average. Viral load, again, I've already talked about. The rules: start multiple drugs targeting more than one mechanism, so reverse transcriptase and integrase, or reverse transcriptase and protease, or protease and integrase. You get the picture. Maintenance of full adherence to therapy, because that dynamic process is like a spring that's ready to pounce again once you take the pressure away of antiretroviral therapy. Those latently infected cells can spark off and start another fire if you take away the antiretroviral therapy. Starting it as early in the course as possible, treating everyone, and in my opinion, even elite controllers, although there's some debate about that. Low-level viremia is not ARV failure. So there are going to be some people whose latently infected cells are are such numbers that as they just kind of naturally spit off a little bit of virus now and then, which doesn't start a fire because they're on antiretroviral therapy, but you can start measuring it, right? So somebody might not be able to get less than 20 copies or even less than 50, and they may smolder along on antiretroviral therapy at 60 or 65. Those individuals can have detectable viremia, but it's not failure, because you're blocking all de novo infection. You're blocking the infection of these activated CD4 cells. It's just that those latently infected cells are spitting out enough virus where it can be detected. The absence of a robust response. So most people, once you start, let's say these have a baseline of 50 CD4 cells. Most people, when you start therapy, goes up dramatically in the first 6 weeks to about, in the case of 50, maybe 200, 250. That's the normal response. But some people don't get that bump. And that's because there's a release of these CD4 cells from lymphoid tissue. These cells are generally trapped in the lymphoid tissue because of inflammation in the tissue. And then when you stop replication, those adhesion molecules, ICAM, VCAM, stop being elaborated because the inflammation dies down in the lymph node and those cells release. And people with very advanced infection, oftentimes the lymphoid architecture is destroyed to the point where there's not much trapping in lymphoid cells, and you don't get that release. And so all you get is a slow upward increase in CD4. That is not antiretroviral failure. That's just biology. And those patients, even if they don't have a robust CD4 count, still do okay. And then, of course, once you treat people, you get the added benefit of not transmitting the virus to other people through sexual activity, and of course, as we know, mother-to-child transmission. So I've already gone over the medicines that can act at different points in the life cycle between the entry, nucleoside, nucleotide inhibitors, integrase inhibitors, protease inhibitors. And these are the guidelines that I was talking about. This is the most recent version of those guidelines. You can see this was in 2022, and every 2 years since 1996, you can see the compilation there. These guidelines so far have always been updated in JAMA, but you can also go online and get the HHS guidelines that are updated a little bit more frequently. Boiling it down for you, these are the usual initial regimens that usually consist of a strand transfer integrase inhibitor and then 2 nucleosides, usually TDF or TAF, and then FTC or 3TC. And this can be done as a single tablet in the case of bictegravir, or dolutegravir plus TAF FTC or TDF FTC or TAF 3TC. There are some individuals who you can transition over to dolutegravir or lamivudine, and those are folks who are hepatitis B immune, meaning they do not have latent or active chronic hepatitis B, and they don't have resistance to lamivudine at baseline. And those individuals you could treat. If you see, look down at number 3 here, this point, there weren't enough studies done on greater than 500 copies or people with more advanced, but generally speaking, those individuals probably can be successful, especially if you start on, say, something with a big TAF FTC, get under control, and then you can switch over, provided those other caveats are covered. During pregnancy, complicated, at the Ryan White meeting, there's going to be a wonderful presentation by Gene Anderson that will go over this, but what's changed is that dolutegravir TAF and either 3TC or FTC is the treatment of choice as a rule, and the other drugs can be used as well. So I mentioned treating everyone, including elite controllers, and this is because of that inflammation that I referred to. So people that are on antiretroviral therapy have less inflammation than those who are not. The elite controllers are able to control HIV replication with the immune system itself, but in my opinion, it's with a cost, because the immune system now is constantly churning, and that, in the long run, in my opinion, is not a good thing. So I would prefer to treat those individuals over time. We mentioned already that low-level antiretroviral therapy is not failure. And again, it goes back to these latently infected cells that are kind of spitting out virus. If there's enough of these cells, remember that viral load is directly proportional to the number of cells in the body producing virus. The same thing is true if you have a lot of latent cells, and that's usually in somebody who had initial therapy at the beginning, had a lower CD4 count, or especially a higher viral load, which means that there were more latently infected cells. We talk about resistance, so let me go into a little bit more biology with you to explain where that comes from. So we're now on a lymph node. I'm in a microscopic area of the precortical region, where mostly there's CD4 cells living. So in this picture, this is the actively infected cell that lives on the order of about a day. Remember that. And over the course of its lifespan, it's going to kick out a certain number of viruses. That's called the burst size. We don't really know the total burst size, but we can estimate it to be at least 1,000 to probably up to 1 million virions in a 24-hour period coming out of this single infected cell. And in the environment around it, most often, there are these yellow cells which are unactivated, right? Unactivated CD4 cells, which we've already talked about, are not susceptible to infection. But every now and then, this cell comes by that's activated, and right about it's shooting out its virus, and boom, it binds, enters, and infects. And remarkably, this happens about once every 24-hour period, such that as the center cell dies off, it's replaced by precisely just one newly infected cell. That's kind of how the steady state is maintained, and why in an untreated person, if you were to measure their viral load daily, which we did back in the day when we first stumbled onto viral load, it remarkably stays constant. 30,000, 31,000, 29,000. It doesn't vary despite this incredibly dynamic situation that we know is going on now biologically. It's just miraculous. So when you give antiretroviral therapy, what you're doing is you put basically a condom around this cell, or a force field, however you want to define it, but it can't bind and enter, or it can't go through reverse transcriptase, or it can't integrate, and it can't, in the case of this virion coming out, mature into an infectious virion. And as this cell is protected, the center cell is eliminated, and it's not replaced, and therefore viral load drops precipitously. If you only have partial protection of this activated cell in the upper right-hand corner, look at it more like a picket fence. So we saw this a lot in the early days when we were trying to prevent moms from infecting their babies, and we gave single therapy with nevirapine. And if it just so happened that this virus, just by chance, produced a virion here that happen to have a Y183 mutation. Y183 mutation, 181, I'm sorry, Y181 mutation, that virus would then come up and infect this cell up here, break through. But here's the issue. Once this cell gets infected with that virus, every virus that this cell now produces as it takes over, every one of them has a Y181C. Every one of them. So within days, and I'm not exaggerating, within days of that infection happening, the population of virus starts to change from 100% wild type to within 2 weeks, 50% Y181C, and within a month, 100% Y181C. That's how dynamic and how fast resistance can happen. So the punchline is we don't want to give partial therapy. And that can happen by not having a robust enough regimen to start with, and it can happen if people are only taking their medicines intermittently, so that the protection of that upper blue cell suddenly just drops to a point where a mutated virus just happens to come by and infects, and boom, despite the fact they're on therapy intermittently, they end up getting infected. Their virus transitions to a resistant virus that becomes a dominant species, and the regimen doesn't work anymore. The way you can work through that is going to these resources. Here's an IAS-USA resource that has been published a lot over the years. One of our colleagues, Vicki Johnson, who recently passed away very sadly, was one of the driving forces behind that. So I'd like to dedicate these comments to her, because she really helped pull this drug mutation document together back in the day. You can download that, as you can see on this slide over here, or you can get these resistance mutation charts that you see on the right, on the left side. But there are other resources. A really good one is a Stanford database, which you can plug in your mutations, and it tells you, relatively speaking, which drugs ought to work against that particular virus. Going back a little bit more to basics, the HIV genome is about a 9,000 base pair virus. The action for most of the drugs is in the pol region, where the protease, reverse transcriptase, and integrase enzymes are produced, and any mutations in these regions can lead to resistance. The way that I went ahead and sort of referred to the Y181C, but here's a common one. This is the baseline amino acid that is the wild type virus, and at that position, if it mutates over to a valine, you get an M base, that's the wild type, 184 position, 184 valine, and that creates resistance to 3TC and to FTC, but that's the nomenclature that's used. And this is a close-up of the resistance mutations. You can see, if we just look at lamivudine, the unique mutation out here, this M184V, or it could be M184I, isoleucine, that leads to high-level resistance and so forth. You can also get a phenotype, and so at the bottom you can see here's that M184V, and you can see that what normally happens, this is where the blue is where the drug is active based on its level in the bloodstream, but you can also see here where the emtricitabine, the FTC, and the 3TC have high-level resistance. There's no mutations you see here. Interestingly, zidovudine and tenofovir become hypersusceptible, meaning the drugs work even better, those two, against a virus that has an M184V, but that's in more of the advanced class that we'll cover another day. The integrase inhibitor resistance mutations, the key ones are 184, 140, 155, and 263. Are you ever going to remember that? Maybe over the years you'll kind of get that down, but mostly you'll be using either these maps or you'll be using the Stanford database. Wrapping up, the absence of a robust CD4 count is not antiretroviral therapy failure. We talked about this already, but here it is graphically. In most situations, as the viral load drops, the CD4 count bumps up dramatically in those first 6 weeks, due, in my opinion, to redistribution of virus of cells that were trapped in lymphoid tissue because of inflammatory adhesion molecules when it gets loose. But in the few situations, you end up with a situation where that release doesn't happen. And so at 6 weeks, the CD4 count hasn't changed much. If you look real carefully, the slope of this line after 6 weeks is parallel to this line. So that all that these people are missing is that initial bump. And otherwise, the recovery over years is very similar to what you see in people that got the bump among those who didn't get the bump, which all kind of makes sense, at least to me. And we'll finish with a comment that undetectable equals untransmissible, and that is one of the other huge benefits of antiretroviral therapy. We not only help the individual, we also help others in the community not be exposed to the virus, because when the viral load goes below really 1,000 copies, but certainly less than 200, transmission doesn't happen. And that's from mom to baby or from person to person through sexual activity, and to some probably good degree among people that share intravenous works. So in conclusion, understanding HIV life cycle is critical to the understanding of antiretroviral therapy. I hope I've convinced you of that. ARV therapy interrupts replication completely, halting most of the damage done in the immune system by HIV. The therapy protects uninfected cells from becoming infected and has no effect on cells already infected. And most of those cells, 99+%, are dead or no longer with us after about 1 to 2 days, but there is a latently infected pool that can live, and that's our barrier to cure. Targets are specific within the viral life cycle. We initiate therapy with usually an integrase inhibitor and 2 nucleosides, and the initiation of therapy may be delayed with certain OIs. I didn't go into that, but you can find that in the guidelines. So I think I'll close here. We're going to have questions and answers at the end, and I'm going to turn over to my friend and colleague, Dr. Bedimo, to take it from here.
Thank you so much, Dr. Saag. It's always a treat to listen to Dr. Saag's eloquent presentation of HIV treatment, care, and pathogenesis in this instance. So correct me if I'm wrong, Dr. Saag, but what you told us is how HIV impacts the immune system, how antiretroviral therapy works, and what it takes for it to succeed. And a corollary to that is that we need to define success. What is not failure is low-level viremia and poor CD4 count. What I would like to follow up on that is there a reason to fix what went broke, i.e. optimize antiretroviral therapy even in people who have success and who are not failing, like you said? So this is what I intend to show, that we can describe the general principles of antiretroviral optimization in the setting of success, virologic suppression, identify comorbid conditions that can impact the survival of people with HIV, even in the circumstances where the antiretrovirals are doing what we intended for them to do. Then select antiretroviral regimens in people with HIV who have increased cardiometabolic risk and sometimes renal dysfunction. So this is a picture of success, which is I like this picture because it shows you how the survival of people with HIV has been significantly impacted by the subsequent generations of modern antiretroviral therapy. Back in the mid-90s, when Dr. Saag and others were developing the concept of measuring viral load and the initial antiretroviral regimens were being developed, this gap in the survival of people with HIV and those who are not infected was significantly wide. That gap has narrowed subsequently. Every 5 years or so, you see these curves ever so slowly getting close to each other, but that gap remains, and the remaining gap is the subject of our discussion today because it's mainly driven, that remaining gap, by morbidities, comorbidities that either happen more frequently in people with HIV, but actually may sometimes be enhanced by the antiretroviral drugs, which we need desperately to save people's lives. So this mnemonic I subject to you is that of a stiff cost. This is to walk you through the reasons for optimizing a regimen that is suppressing the virus. Number one is simplification. Sometimes in your clinic, you will come across people who have a suppressed viral load, but that has been achieved at the cost of multiple really complex regimens. And it may be possible with the newer, more efficacious drugs to simplify those regimens. And now it may be possible to switch some of these people to long-acting injectable antiretrovirals. We will hear about all that at the Ryan White conference, and Dr. Connie Benson will talk about what is new and upcoming in antiretroviral treatment. The second reason, the T, is tolerability. We may need to enhance tolerability and decrease toxicity. People might have gotten used to these old regimens because they saved their lives, but at the expense of significant gastrointestinal tolerability, cardiovascular morbidity, and others. We can improve that. So we can fix what ain't broke yet, but that's likely to break. So interactions. Now, as our HIV population is aging, there are a number of other drugs that they need to take for their diabetes, to hypertension, and other things. We may need to mitigate, prevent drug interactions. We might need to work around food and fluid requirements. And some of our people living with HIV might either get pregnant or consider pregnancy. And so we need to work around what antiretrovirals will be optimal for the pregnancy. And then finally, we might be able to decrease the cost. So, and this is what the improving survival of people with HIV has highlighted, an increasing burden of non-communicable diseases. And there's a number of people now who will be living with 2, 3, 4 non-communicable diseases, from cardiovascular disease to diabetes to osteoporosis and non-AIDS malignancy. So we need to be on the lookout for those. And why do they develop this? We will come to that later. But first, do no harm. Whenever you're switching antiretroviral therapy to address these possibilities, you don't want to lose sight of the number 1, the number 2, and the number 3 reasons for giving antiretroviral drugs is to suppress the virus. So you want to keep that at the front of your mind. And then you want to review the history. History is very important. The person may have failed other treatments in the past. They may have had toxicities to other regimens in the past. They may have had interactions. This history is important to take into account as you decide or to switch the antiretroviral therapy. Some of the drugs that people may have taken in the past are what we call a low genetic barrier. Dr. Saag mentioned to you the M184V, which is a very common mutation and that is brought about by exposing the patient to these drugs, 3TC or FTC. There are others. So when a person has taken efavirenz, EFV, 3TC, FTC, the older generations of integrase inhibitors, and the failed regimens contain them, it's important to assume that they have developed resistance to them if you don't have any other data. So assess prior resistance before you switched, because like Dr. Saag said, that that virus that has been mutated infect cells, and those cells may go to be dormant, and that those mutations are quote unquote archived. So with a history of multiple failure, you may need to consider additional testing like proviral DNA to find out whether you may have had those archived mutations. Now, it is a possibility for people living with HIV to have another virus on board. In the US, it's mostly hepatitis C, chronic hepatitis C. And around the world, chronic hepatitis B is also a bigger issue. Co-infection of hepatitis B with HIV might compel you to use antiretrovirals that are also active against hepatitis B. So if the person was taking an antiretroviral regimen that contained 2 drugs active against hepatitis B and you switching them, you may want to make sure that you maintain at least a couple of drugs in the newer regimen that also act against it. This is incredibly important, or the hepatitis might flare, and that may be actually life-threatening. Now, consider other comorbidities like we talked about with drug interactions and potential for pregnancy. And this is a triad that I want people to keep in mind all the time when you're assessing the pathogenesis, the presence, or the possibility of non-infectious complications in people with HIV or comorbidities. Some of them are because people with HIV have social, demographic, behavioral factors that put them at a higher risk of these things, like smoking. Then comes the virus, like Dr. Saag said, it increases immune activation and inflammation, and these things are drivers of a number of chronic complications, including cardiovascular disease and cancers. But we, of course, don't have the luxury of talking to these people living longer if they're not on treatment. That treatment itself, antiretroviral therapy, may bring about some complications that heighten the risk of metabolic complications, as we will discuss later. Simplification is easier now than ever because almost all the classes of drugs can be co-formulated into single tablet regimens. When in the mid-90s, antiretroviral therapy was somewhat optimized and was called highly active antiretroviral therapy for the first time, it is because it really worked maximally to suppress viral replication, like Dr. Saag said. And then multiple generations of combinations of medications were done. But until about a couple of years ago, the sweet spot of antiretroviral therapy was always 3 agents, either used singly or combined in one pill. The triple therapy was the sweet spot until recently, when you see these 2 regimens at the bottom. Now we can actually effectively treat HIV with only 2 agents, and that could be co-formulated. Now, this simplification could also be a less is more principle, where you're moving from regimens traditionally containing 3 drugs to 2 drug regimens. And these are multiple studies that looked at different regimens. And the one that Dr. Saag pointed out that is now in the guidelines for initial therapy is dolutegravir 3TC. And then probably others will be coming soon. Again, do not forget that if somebody is co-infected with hepatitis B, even when you're simplifying them, like Dr. Saag mentioned, you cannot simplify that person with hepatitis B to dolutegravir 3TC because it only has 1 drug active against hepatitis B, not 2 as recommended. Tolerability can be increased because of this type of studies. This one was at Mass General, one of the first studies to show us that, yes, people with HIV, whether men or women, on the left or on the right curve, and at all ages, have a higher risk of osteoporotic fractures than the general population. Now, so it's important to decipher what that risk is. Again, always remember, background risk imparted by HIV inflammation and chronic immune activation, and risk imparted by the drug. You cannot necessarily easily tease them apart. But can you improve those risks by switching the antiretroviral therapy? Now, on the left, you see studies showing that if you use the newer generation of tenofovir alafenamide in green at initiation of antiretroviral therapy, you preserve bone function better than when you bone mineral density, better than the older formulation of tenofovir in red, tenofovir desoproxil fumarate. The other considerations now are that you may also have a higher lipid and a higher potential for weight gain. So always balance these things. On the right, what is the circumstance with integrase inhibitors? In instance here, dolutegravir versus protease inhibitors that are boosted, is that your lipid profile, either triglyceride, non-HDL, LDL, there is much better across the board But additional consideration, inflammation markers decrease as well, but so does adiponectin, which has been associated with a potential for weight gain. So they are antiretroviral regimens are getting better, but we still have some safety signals that we need to pay attention to when we make changes. And the advanced study, I like to refer to it in South Africa because it's very aptly named. It actually did advance our knowledge about weight gain in antiretroviral therapy. And what that advanced study shows that in men and in women, regimens that contain integrase inhibitors, dolutegravir here, or the newer formulation of tenofovir TAF, that is a regimen in red, are associated with more weight gain than regimens that contain only one of them, only dolutegravir in blue, or regimens that contain neither of them, the older formulation tenofovir TDF and efavirenz in green. Things were a lot worse for women. They gained twice as much weight as men. That is something that we have now seen in a number of other studies. But what I like in this is what is at the bottom. When you look at the consequences, the possibility of weight gain in people with HIV, just know that it is not the majority of people who gain weight. It's a minority. So what you want to see is what is the proportion of people who gain a substantial amount of weight. Here, over 10% of change in body weight. You can see that that proportion was a quarter in regimens that contain dolutegravir plus FTC-TAF. At least what we know now is that we owe our patients candor by telling them that we don't fully understand the mechanisms of this, but you said there are certain demographics, i.e. women here, but also Blacks, who are more likely to gain weight. And if we don't say that, we might lose their confidence in us. Tolerability is another issue in that concept of weight gain, which we have seen grapple with in the past 5 years. An easy thing to think about is, well, but let's switch to another antiretroviral regimen. In this instance, well, this is one of the newer studies where people try to switch patients from these integrase inhibitor containing regimens that I've just showed you in advanced study was associated with more weight gain to a protease inhibitor-based regimen. And I don't need to tell you more because these two curves here completely overlap each other. There is no difference between in weight change between the integrase inhibitor arm and the protease inhibitor arm. Now, I put here that should we be surprised, because I don't really think we should be surprised, because there are some initial studies, and this is the NA Accord 3 years ago, that already suggested that protease inhibitor-based regimens were associated with almost as much weight gain as integrase inhibitor-based regimen. So it's important to keep that in mind. And this is another study that showed that switching people from protease inhibitor to integrase inhibitor actually did not lead to more weight gain, but actually almost the reverse. So when we say that weight gain has been shown in a lot of people with integrase inhibitors, let's not forget that protease inhibitors may not be very far behind. In terms of switching for weight gain, another advance is also come from South Africa, from the advanced trial, where they tried to switch people from regimens that led to more that people were randomized to a regimen that the country decided that everybody would be on that regimen, dolutegravir 3TC TDF. And when they did so, they showed that those who were in the regimen that was associated with more weight gain drop weight. Those who were in the middle stays in the middle, and those who were in the regimen that was associated with less weight increase weight. So we need to learn a little more about those. To finish the book on tolerability, the T is that let's have some caution also with the newer agents like integrase inhibitors, because a smattering of studies is beginning to suggest that they could, at least numerically, even if as many of them, it wasn't statistically significant. There have been suggestions of higher changes in blood pressure compared to other regimens. What created a lot of turmoil in the past year was whether these regimens of integrase inhibitor-based regimen were actually associated with increased cardiovascular risk. Now, that is a big concern if that was true. And this is a collaborative study in Europe that showed that exposure to integrase inhibitors were associated with a 2.5-fold greater increased incidence of cardiovascular disease within 6 months of exposure compared to no exposure to this. And that created a lot of concerns, and people were practicing HIV about 15 years ago know that we've been there before with another drug called abacavir, where early exposure to abacavir was also associated with an increased risk of cardiovascular disease. And the story after that remained incredibly murky, as some studies confirmed this, other studies did not. Now, again, similar to the story with abacavir, we have seen that another study, also in Europe, in Switzerland, this time, confirmed that cardiovascular disease events were more likely to occur in people initiating integrase inhibitors, but after they adjusted for calendar year demographic HIV variable, other comorbidities, use of lipid-lowering drugs, and so on and so forth, there was no longer any difference. So it's important when you pass those studies to find out whether the control they did the appropriate controls. So again, special attention to older patients, polypharmacy, low bone marrow density, and history of fractures. Consider that you may switch people from the older tenofovir formulation to the newer one, or to abacavir. For those with high cardiovascular risk, if they were on abacavir, consider switching them to the tenofovirs, TAF or TDF. If they were on ritonavir, cobicistat boosted protease inhibitor, which also, especially darunavir, has also been associated with increased cardiovascular risk. So it's important to think about switching them. If they're chronic kidney disease on TDF, also be better to switch them to the newer tenofovir, TAF, or abacavir. Same in atazanavir, ritonavir was also associated with renal toxicity. Weight gain, like I showed you, uncertain benefit of switch thus far, save this characterized cohort in South Africa. However, it's also important to balance other potential benefits of integrase inhibitors. Better virologic response, lipid parameter is better. And then when we switch, we have to just think about balancing. Our population is getting considerably older, which is a good thing. This is a testament to the success of antiretroviral therapy. However, with aging comes the need to balance the management of a lot of comorbidities with the risk of polypharmacy. This is just illustrating to you that polypharmacy is really, really common in people with HIV who are taking an average of 12 medications, 12, including non-HIV medications. And this is measured, the inappropriate prescribing is rampant. So always be on the side of paring down the number of medications that people take. And here, this Beers criteria is not the number of beers they take at the bar per week, is one of the measures of inappropriate medication. So be on the lookout for that. Again, closing on the interactions and with co-medications, this is just a digest of some of the most important. A lot of our patients are taking medications as well as substances over the counter, say multivitamin. A very important thing to find out, those that contain a lot of these polyvalent cations, aluminum, magnesium, calcium, can bind integrase and decrease the exposure and cause viral load to be detectable. So be on the lookout for that. Direct-acting anticoagulants, they increase exposure. The exposure is increased by valtegravir, cobicistat, be cautious. Anti-seizure medications, some of them are taken for prevention of seizures as well as some other indications. they may decrease integrase inhibitors exposure. So it's important. If it is carbamazepine and the person is on dolutegravir, they could switch to taking BID. Metformin can increase bictegravir and dolutegravir exposure, and so it's important to exercise caution and look for toxicity from my friend like lactic acidosis and other things. So rapamycins might decrease integrase exposure. You can use rifabutin with dolutegravir, rifampin, not so. And so it's important to look at that. Either somebody is CBE treated for active or latent tuberculosis. Steroid exposure, the exposure increased by elvategravir cobicistat. That is very important, even when somebody is using inhaled one like fluticasone. They may have increased exposure of these drugs, so it's very important. And then statin, PPIs, 20% of Americans have taken some anti-acid medication, including proton pump inhibitors. Very important to see if they're on artesunavir or ribavirin. And then finally, statins. We will have a lot of statin discussion at the Ryan White conference with the reprieve investigator themselves, but it's also important to know that there could be drug-drug interactions. Pregnancy will be talked about, so I won't belabor the point, just to show you that a lot of medications that are preferred for everyone have not yet have sufficient information in pregnancy, unfortunately, and that includes bictegravir, so be cognizant of that. However, the newer data suggests that regimens containing dolutegravir, which were thought in the past, 3-4 years ago, to be really bad for pregnancy because they may increase neurotube defect, are now shown to have not just better outcome for women, but also better outcome for pregnancy, stillbirth, low birth rate, and other things. So this will be talked about at the conference as well. So this is just a digest. So staying on F as female fertility, consider drug interaction with hormonal contraceptive, gender-affirming care, and pharmacokinetics in pregnancy. So efavirenz, thankfully not used much anymore, might decrease exposure to progestin, so possible risk of oral contraceptive failure, no significant impact on injectable contraceptives. These are nitty-gritty that may be important as HIV care become more open to people who don't do that every day. And then during pregnancy, an additional goal for antiretroviral therapy is reduce the risk of transmission of HIV to the fetus or newborn. And I just talked to you about the IMPACT-210 study that showed that dolutegravir-based regimens may be much better for that than others. Now, in terms of cost, less is more, as two-drug regimens. Just yesterday, another article was published about two-drug regimens and how they could possibly be more cost-effective. In the article from yesterday was in the PrEP regimen for TDF FTC, but it's also important to consider cost depending on what setting you practice in and who the payers are. So stiff costs, simplification, tolerability, interaction, food fertility requirements, and food and fluid requirement, and pregnancy fertility, as well as cost. So I hope we went through a sort of digest of what might be in need of fixing when it ain't broke, and so I would leave it there, and then I'll pass it on to Dr. Saag.
Great, well done, Roger. Thank you very much, and we're going to wrap up here with Dr. Thompson's presentation. I'm realizing that our talks are going about 30 minutes, so that means we're not going to have as much time as I'd hoped for Q&A at the end. So what we're going to do is we'll answer the questions in the Q&A, just written, to make sure that we get the questions answered. And hopefully, with whatever time we have at the end of Dr. Thompson's talk, we'll hit some of the high points before we close out. So without any further ado, Dr. Thompson.
Thank you very much. The pressure is on here, so it's bad enough to go after Roger and Mike, who are two of my favorite speakers. But I'm really excited to be able to talk with everybody today about vaccinations, because it's kind of vaccine season, isn't it? Every season is vaccine season, but we're doing a lot of it right now. I hope at the end of this talk, you'll be able to better manage immunizations in people with HIV, and particularly those for hepatitis B and pneumococcus. So today's menu is that we're going to focus on 6 different types of vaccines, and I would encourage you to attend Dr. David Spock's talk on immunizations during the Ryan White conference. He'll go into a lot more details than I can go into today. So what's special for people with HIV? First of all, I think we should all be aware of what we shouldn't give to people with HIV. Live attenuated influenza vaccine, live attenuated smallpox, that's ACAM 2000, that's also given for Mpox. These are contraindicated for everybody with HIV. Now, we also have some vaccines that are contraindicated for people who have low CD4 counts or uncontrolled HIV, and that would be live attenuated typhoid vaccine, the MMR vaccine, varicella, and yellow fever. So I want to talk a little about COVID and HIV. People who have CD4 count less than 200 are at high risk for bad outcomes from COVID and also death. And it also appears that people who have lower CD4, or people with HIV, regardless of CD4 count, who have had prior COVID, may be more likely to become reinfected with COVID than people who do not have HIV. So it's really important that we vaccinate everyone with HIV. The principles are pretty much the same as with the general population, as long as their CD4 count is good. But for those people who have advanced or untreated HIV with a CD4 count less than 200, we want, if they have not had any vaccines, we want them to have 3 homologous doses, that if they're Pfizer, all Pfizer, of updated mRNA, or 2 doses of the updated Novavax vaccine. Next. And then if you're boosting them, basically, if they've had only 1 prior mRNA vaccine, these folks will get 2 boosters, and they will only get 1 dose if they have had anything else. So more than 2 doses, or a Novavax or a Janssen vaccine. Okay. Let's advance. There we go. So now we're going to move into pneumococcus. This is a little more complicated. So I want to go over some basics. First of all, we have 2 types of vaccines. Conjugate vaccines take polysaccharides and join them to a non-toxic diphtheria toxin to improve the immune response. And the number of serotypes that will be represented in a vaccine is right there in its name. So for Prevnar 20, you know that this represents polysaccharides from 20 different serotypes. Now, everyone needs a pneumococcal conjugate vaccine, and ideally this would be their first vaccine. For the polysaccharide vaccine, we really only have one that we use, and that is PPSV23. And this takes polysaccharide antigens from 23 different types of pneumococcus. And it's important to remember that you pretty much have to use PPSV23 as part of the series unless you are giving PCV20. Next. And we do have some new kids in town, PCV20, PCV15. And I want to point out that we have data in people with HIV for PCV15, but we do not have data for PCV20 yet. Next. So this is really complicated, and there's sort of an alphabet soup. And so I want to talk about what some people are calling the one and done method, using a single dose of PCV20 to complete any vaccine series. So here we are with someone who has no prior pneumococcal vaccines or unknown vaccines. You can give them either PCV20 or 15 next. And if you give PCV20, you are done. They right now do not need any more vaccines for the rest of their life or until the guidelines change. Next. If you give PCV15, then at least 8 weeks later, you're going to give PPSV23, and then they are done. So really only 2 vaccines. If someone has prior vaccination with PCV13 or PPSV23 alone, then for either of those scenarios in 1 year, next, you are going to give them, you can give them PCV20, and again, they're finished. Their vaccination series is done. Or next, if you give 1 dose of PCV15 to a person who has had the polysaccharide vaccine, they also are done. So it's getting simpler. Next. For people who have had both the PCV13 and the PPSV23 vaccines in the past, and that could be 1 dose or 2 doses of the polysaccharide vaccine, next, you can, at least 5 years later, give a PCV20, and they are done, even if they are age 65. And next, if you want to stay with the polysaccharide vaccine, you can give them another dose of the polysaccharide vaccine after age 65, and then they are also done. Next. There is a provision for people who are over 65 and who have had mainly the polysaccharide vaccines and an earlier PCV13, that you could give them 1 dose of PCV20 at least 5 years after their last pneumococcal vaccine dose, and that would be based on any increased risk they might have for exposure or if they are at risk for severe disease. Next. So the pros are that this one and done PCV20 method is so simple, and there is an adherence advantage to that. You also have only 1 vaccine to stock. Next. But we don't have clinical outcome data with PCV20 for people with HIV, especially those with impaired immunity or unsuppressed virus. It is more expensive as a single dose than the other vaccines, but probably not more expensive than an entire vaccination course. So let's shift to respiratory syncytial virus, RSV vaccine. We now have 2 new vaccines approved for people 60 years old and older. And we give these with shared decision making, and we'll talk about that. But the 2 vaccines are from GSK and Pfizer. They're similar in that they both have, they're both based on a recombinant pre-fusion protein. But the GSK vaccine has an adjuvant, which is actually the same adjuvant that they use in their Shingrix vaccine. Now, we don't have any HIV-specific data on these vaccines either, but we do have some guidance under immune compromise. Next. So this vaccine would be recommended for people who have advanced HIV, providing they meet the age criteria. Or many of our patients who have diabetes or other bad organ system diseases, cardiovascular, lungs, kidney, or who are frail or of advanced age and maybe living in nursing homes or long-term care facilities. Next. So now we're going to dive into hepatitis B vaccination. This is a little bit complicated, but I think it's getting simpler. First of all, there are 4 treatments that we normally are using now for hepatitis B. There is a 5th vaccine that is approved, but actually we have no data in people with HIV, and it's not in the OI guidelines, and that's called Prevebrio, and I'm not going to talk about that today. So if we look at our typical vaccines, we have 2 recombinant vaccines, and we give them as a 3-dose series at double strength, and that's important. People with HIV get double strength hepatitis B vaccines. We also now have a recombinant adjuvanted vaccine, which is Hep CpG or Heplislav B. So the Heplislav B is a 2-dose vaccine, and it's given at 0 and 1 months. We also have a combination A and B vaccine called Twinrix that is given 3 times, so 3 doses. Next. So remember, when we're giving hepatitis B vaccines, it's really important to vax and verify. So check those hepatitis B surface antibody titers 1 to 2 months after the last dose. And if those titers are below 10 milli-international units per mil, that is not responsive, and that person needs to be revaccinated. And we'll talk about that. Remember, if somebody has a low CD4 count, this might be an instance in which if you're starting them on antiretroviral therapy, you might wait a minute to do the vaccination until their CD4 count rises a little, but that depends on their risk for hepatitis B. So the not-so-new kid on the block, it was approved in 2018, is Heplisav B. Now, this has an adjuvant that is a toll-like receptor agonist to boost the immune response. And it was found to be superior to Injerix B in achieving seroprotection in people without HIV. But note, these were 2 doses of Heplisav B versus single-strength Injerix B, and that's not the way we vaccinate people with HIV. But there's an interesting study in chronic kidney disease, also for people without HIV, but these folks have more difficulty mounting an immune response. So they used 3 doses of Heplisav B and found that 89% of people were able to achieve a seroprotective response that's greater than 10 million national units per mil, compared with 81% who received Injerix B at double strength with 4 doses. So that's a very good response. Next, just a reminder that we do not give this vaccine in pregnancy due to insufficient data. Next. And these are the data that are likely to change our practice. This is an interim report from an ACTG study. It is a single-arm study, open label, in 74 people. And note that these people had pretty high CD4 counts, so in the 600s as a median. And they almost all had viral suppression. And interestingly, 2/3 of them were from Thailand and had a pretty low medium BMI, which is different than for America, and particularly here in the South. But the results were quite remarkable. And if you look at the results of 2 doses, so before dose 3, they were able to see a seroprotective response in 95 to 98% of people. And then after dose 3, the response rate was 100%. And this is quite remarkable for hepatitis vaccines. And it was also interesting that 88% after 3 doses had surface antibody titers of greater than 1,000. Next. So let's talk about non-response and what we might do for these folks. If immunity is not achieved after a full series, then you're going to revaccinate with a full series. So that's 3 doses of double strength recombinant vaccines or 2 doses of Heplisav B. And this is also a time when, if you think the CD4 count is going to rise, you might wait a little bit to revaccinate to give them the best chance for an immune response. Next. But there's some other strategies. So you could use just 1 dose of any hepatitis B vaccine and then check the titers in 1 to 2 months, but you will have to complete the full series if the titers are still low. Now, based on this Heplisav data that I showed you in people with HIV for 3 doses, and also the data in chronic kidney disease, you may consider giving a 3rd dose of Heplisav B and then checking to see what the response is. Some people are also recommending giving the full 3 doses as the initial series for people who have low CD4 counts. Next. So everybody remembers Mpox, right? This was the dramatic outbreak that occurred last year. We were up to almost 450 cases per day on average for a 7-day average in the summer of 22. But now we're down to a 7-day average of about 1 case a day. But there have been some outbreaks. And we have to remember, Mpox is not gone, and we are going to see it again. And some places continue to see low case rates of Mpox now. Next. So people with Mpox and HIV who have low CD4 counts are really at quite high risk for severe disease and also death. There have been several series presented looking at people with low CD4 counts. It's been found that there are more severe complications if the CD4 count is below 100 compared with above 300. Remarkably, 87% of Mpox deaths in this study in the MMWR were non-Hispanic Blacks. And I just have to get on my equity soapbox here for a minute and remind us that we have to employ an equity approach to vaccine distribution so that the people most in need are able to get the vaccines. Also, 94% of those who died in whom we knew their HIV status did have HIV, and almost all of them had a CD4 count less than 50 if we had CD4 information. And unfortunately, for those who had treatment information, only 8% were on antiretroviral therapy at the time of Mpox diagnosis. So this tells us a lot, not just about Mpox, but about how far we have to go in our HIV response in America. Next. The good news, however, is vaccines work. So there have now been several observational studies that are very reassuring, that are not seeing deaths or hospitalizations, even with breakthrough infections in people with Mpox, and also a lower frequency of these severe manifestations like genital, ocular, mucosal lesions. And in a cohort in Seattle, the vaccine was found to be about 83% effective. So these are very reassuring. Next. And it's really important that we encourage people to get both doses of the vaccine. Our rates for that second dose are really not very high. We really need to do much better. So these are brand new ACIP recommendations from the last week in October, recommending the 2-dose Jynneos vaccine series for persons at risk. And next, here are how persons at risk are defined. So people who are gay, bisexual, other men who have sex with men, transgender or non-binary, who in the past 6 months have had a new diagnosis of at least one STI or more than one sex partner, people who have sex at commercial sex venues or at parties in association with big public events where Mpox is transmitted, and also the sexual partners of people with those risks. And the last bullet, I think, is really important. Persons who anticipate experiencing any of the above. And so many, many people fall into that category. So let's get them vaxxed now. Okay, meningococcal vaccines. This is pretty easy because it's just 2 doses of the quadrivalent meningococcal vaccine, at least 8 weeks apart. And then you would repeat every 5 years. Now, there is also a meningococcal B vaccine that is not currently recommended for all people with HIV, but there are people to whom we would want to give this vaccine if they meet the criteria. I want to mention that this vaccine is being studied for gonorrhea prevention, and there were some very exciting interim results at CROI from a French study. Unfortunately, these were interim results, and the final analysis did not bear out this exciting news. So there is a separate trial going on, but right now we don't have the data to be giving meningococcal B vaccine for gonorrhea prevention. But we do have a new vaccine in the meningococcal world, and that is a pentavalent vaccine in which A, C, W, and Y are now paired with B. So for people who need B, you could give them that combination vaccine if they need both of the vaccines at the same visit. So I just want to point this out. If you go to the OI guidelines, they have a great resource, which is a super little chart. And I think this is really helpful. Next. I want to point out, if you're giving HPV vaccine, people with HIV always get 3 doses. And if you're giving recombinant zoster vaccine, there is no longer any CD4 restriction. So that can be given to anybody. These are also resources from CDC for pneumococcus. There is an app. So you can download the Pneumorex VaxAdvisor app to help you with this pneumococcal conundrum. And then finally, these are the essential additional resources that might be helpful to you. All of these are in the slides, so you don't have to worry about the links, but these are the things that I look at all the time. And remember that these change pretty rapidly, so do review these when you're facing a new vaccine. Okay, so we'll stop there. Let's go Vax.
Perfect. Thank you, Melanie. I think you'll notice that we answered, I think, all of the questions while we were in the midst of Dr. Thompson's talk, but we're happy to revisit some if you'd like. We got about 3 or 4 minutes for some questions. I think maybe what we can do is I will just kind of go through some of the questions that we answered. I think there were a couple about what to do about blips and when to order a resistance test. Dr. Thompson, how do you manage somebody's on a successful regimen and all of a sudden the viral load is up? Take us quickly through what you do to assess when you need to do a resistance test.
Well, I think if we're talking about low-level viremia, so, this is the kind of thing that it's very important to look at interactions. So has the person started new drugs that could interact? Have they started taking supplements? And, calcium, magnesium, zinc, aluminum, all of those polyvalent type metals can interfere with integrase inhibitors. And then there are a lot of drugs that interfere with non-nukes and some with PIs. So I review their medicines. I don't do anything, frankly. If they're just having low-level blips, I'll keep an eye on them. But I'm not going to order a resistance test for a low-level viral load. Now, if it starts going up, that's the time that we do talk more.
And your threshold is what, about 200 or higher confirmed?
Yeah,
right?
I think 200 is where I begin to get worried, and I think the data support that.
Great. All right, so we got just a few minutes, so we're going to go, 15-second answers here. Dr. Bedimo, what do you do in an HIV hepatitis C co-infected person, newly diagnosed? Which do you treat first? What do you treat second?
Yeah, so thankfully, with newer direct-acting antivirals for Hep C, that question is less crucial. I think it's very important to treat HIV as well, depending on, especially if the HIV viremia CD4 count is low.
Okay. one of the questions was follow up on the elite controllers. I don't mean to get bogged down in that, but briefly, most of the elite controllers followed over time will start to have a lowering or decline in their CD4 counts, and most people will treat. Some people use a CD4-CD8 ratio, which if you look at the CD4 divided by CD8, if that number drops below 0.5, then they go ahead and treat. It's debate. My personal view I've expressed already, but I think the immune system's having to churn, and I don't think that's a good thing. So, as I often say, why not just give air support for the infantry? Melanie, one of the questions is about a patient who comes out of the CD4 count of less than 200, and they're labeled an AIDS patient, and then the number goes up above 200. Do they still have AIDS, or what do you do with that?
You know, I think it's an interesting question. It's sort of once diagnosed, always have AIDS, but that really is sort of irrelevant to us today. So many people come in with low CD4 counts. Now, it's not irrelevant that they did have a low CD4 count at one point, because we know that can influence some of the way they may respond in the future, or their risk of cardiovascular disease or other non-communicable diseases. So it matters. But honestly, I think once they are above that level, we really shouldn't be saying AIDS anymore.
Right, and AIDS was basically a term used in the early 1980s to track a newly defined epidemic for which there was no known cause. And once HIV was discovered in 83, 84, it became anachronistic except for tracking an epidemic. So clinically, it doesn't mean much, and it labels patients a little bit more than they need to be, in my opinion. Roger, maybe we'll finish with this one. A patient who has a persistently lower CD4 count that just never came up, and they're still below 200, above 100, but let's say for several years, and their virus is suppressed. What do you do about PJP prophylaxis, other prophylaxis?
Yeah, this is more of a headache for providers than for the patients themselves. And I think that, like you really clearly articulated, it's not necessarily only the CD4 count, but people who suppress viremia. It's been shown that they have very low risk of opportunistic infection. And that has been clearly proven when the CD4 count is over 100. It's a bit debatable when it's below 100. So above 100, I don't know that it's helpful, that prophylaxis of PJP is helpful to continue. And the bad news is that there's nothing you can do to increase that CD4 count. People have tried everything.
Okay, so some of the questions that just came in, meningococcal vaccine, Dr. Spock will be covering at the Ryan White meeting, and even if you're not going to that, those talks will be online after December 5th or 6th, and also switching from 3 drugs to 2 drugs in a core-only positive individual. Very advanced question, good question. I'm going to be covering that in the ARV talk at Ryan White. And then finally, real quickly, Melanie, HIV patient who has not had a primary series for the COVID vaccine, what do you do?
So if they have good CD4 count, if they're above 200, then you would go ahead and treat them like a general population individual in terms of giving them their new and improved 2023 vaccines. We're not using any of the old vaccines anymore. But remember, if their CD4 count is low, they're going to need 3 doses of an mRNA vaccine or 2 doses of the Novavax vaccine.
Okay. So we've reached the Carol Burnett moment where we've had a great time together, and I have to pull on my earring. But first, we have to go through some final slides here. So for information on how to claim CME for nursing pharmacy pharmacotherapy credits, it'll be emailed by 5 p.m. Eastern Pacific time or 8 p.m. Eastern tomorrow. Your feedback's important, so we'd really like to have you give critique of our presentations. We have a few upcoming events for those who would like to find access to substance use disorder CME. We need 6 hours or so of credit for a lot of us to renew our prescribing DEA. That series is being completed now in the IAS-USA collection. 2 more talks will be coming up here in November. You can see the dates in November, December, and the final one, number 6 of 6, will be happening soon after. We're having a virtual course. We call it the Washington course. Used to be live, now it's virtual. And a really good lineup of speakers talking about reprieve, talking about semaglutide or semaglutide, depending on where you're from, how you pronounce that, but really good opportunity. It's on December 12th, so you may want to think about that. A special webinar on long COVID. Not much we know to do about it yet. The RECOVER study is just getting underway, but at least a state-of-the-art presentation will be on January 16th. And then we have a new podcast that's starting that I have been hosting. Our first sort of live one will be with Dr. Fauci. Should be a great conversation. We could probably go for about a day or two just having a conversation, but it'll be about 30 minutes. And I'm looking forward to that. That's going to happen in early December and be online very quickly. Going antiviral. How's that? Thank you for participating. Thanks to Dr. Bedimo and Dr. Thompson for a great job. Thanks to IAS-USA for their incredible organization that keeps these things not only happening, but happening at the highest level of CME. We're very grateful to that. And without any further ado, thank you. We'll see you next time.
Thank you.
Happy Thanksgiving.
Happy Thanksgiving.